Now, I want all of you youngsters to hear different perspectives on liver dissections and the management of liver tumors and liver diseases, so that you get a whole perspective and will be able to make better judgments in your own practice. So as a part of this thought process, we will be having different people, different faculty members presenting on the same topic. Please do not consider it as a repetition. It is for seeing different perspectives and learning individual tips from the faculty. So welcome to the first lecture on that series. Mahesh will be doing on the management of liver malignancies and principles of liver resection. Mahesh, it's your time.
Thank you, Ilango. I'll just share the screen first. As Ilango mentioned, this is a lecture about liver cancer management and what are the basic principles in doing liver resection. So before I start this topic, always, we say some thing that we need to do to, to change something in anything, like, for management of the disease or something in social activity or something like that. We need to do something to change something. So if you're thinking something to change in a year, you plant a rice. If you think something you're going to change 20 years ahead, plant a tree. But if you're thinking hundreds of years, you educate people, because once you educate people, it keeps on passing through, generation after generation after generation. So the change that what you want to do is, will happen at some point. Now, there are few historic events in liver disease management, specifically from the anatomical point of view. 1951, George is the one who studied about the placement of the bile ducts and the hepatic artery, and he divided the liver into 5 segments. At the time, that was a big revolution. In 1957, and what we use now, the Coinert segments, he divided the liver into 8 separate segments with individual inflow as well as outflow. And another historic moment is Thomas Torsel, who performed the first human liver transplantation in patient with biliary atresia in 1963. So this is an important slide that everybody, I feel is very important, because this actually changed the way that we look at the liver, and we can say how safely we can do the liver surgery. Previously, we are a bit more, we are scared about how, to touch the liver. If we think it might make some injury to the liver, it's going to be disaster. And I clearly remember when I was my PG period, at the time, my assistant professor used to say, whatever you do, never go near the liver. If it bleeds, then the patient will die. That's what the statement I used to receive, but I think it's no longer applicable now. And we all think liver tumors, especially if there is a secondary liver tumors, we think that is the end of the game. So still now, a lot of our own fraternity, not in our specialty, but different specialties, as well as people in the periphery, think when the patient develops a liver cancer, and that is the end of the game. This actually, the presentation is just to give an insight about what are the options that we do have for patients with liver malignancy. There are 4 types of tumors that we can get from the liver. One is the primary solid benign tumors. We all know hemangioma, FNH, and all those things comes under benign tumors that I'm not going to go into it. And then primary solid malignant neoplasm, which we are going to discuss a little bit. Cystic neoplasms of the liver itself is a separate topic. And I'm going to touch upon metastatic liver tumors as well. So malignant liver tumors, primary, we all know hepatocellular carcinoma. We had an exhaustive discussion about hepatocellular carcinoma in the past couple of sessions. Then cholangiocarcinoma, it can be intrahepatic or hilar. Then cystadenocarcinoma, angiosarcoma, non-Hodgkin lymphoma, and epithelioid hemangioendothelioma. Secondary, we divided the secondary into colorectal liver metastasis, neuroendocrine liver tumors, and non-colorectal, non-neuroendocrine, because the management of colorectal and neuroendocrine tumors have advanced a lot than other secondaries. So just a brief touch upon hepatocellular carcinoma. Normal liver gets a hit, either hepatitis C, alcohol, or NASH, whatever, it become chronic hepatitis, then cirrhosis, then become HCC. And is the most common primary tumor of the liver. It's a leading cause of death worldwide, and almost like 1 million deaths a year, and mostly occurs in patients with liver cirrhosis or chronic liver disease. once the HCC is diagnosed, mostly 1/3 of the patients are suitable for surgery, either surgical resection or transplant. But other patients have different modality of treatment, which we have discussed last time, like ablative therapy, local regional therapies, SBRTs, and systemic therapies. I'm sorry. So this is actually a slide of an HCC. You can see the background cirrhotic liver. There is an intraoperative ultrasound scan being done, and you can see the lesion on the picture on the left side. And radiofrequency ablation, we discussed last time, child A/B solid tumors, usually less than 3 centimeters are suitable for radiofrequency ablation. And chemoembolization, like a transarterial chemoembolization TACE, another option for HCC. Again, HCC management is multimodal. It can range from liver resection, transplantation, ablative therapies, radiotherapies, systemic therapy, and palliative care and best supportive care. So the HCC has got wide variety of modality of management depending upon the liver disease as well as the stage of the tumor. Cholangiocarcinoma, bile duct carcinoma, 10 to 20% of all liver cancers. Risk factors are primary sclerosing cholangitis, bile duct cysts, parasitic infection, and hepatolithiasis. Again, it has also got few options, including transplant. I would say transplant because there is an option for transplant for cholangiocarcinoma as well. In secondary liver metastasis, most common site for bloodborne metastasis. Common primary is the colon, breast, stomach, and pancreas. Treatment depends upon the primary cancer. Again, as we all thought in the past, as well as most of our medical fraternity, things like liver secondaries is the stage 4 disease, it's end of the story. No, there are a wide variety of options available to treat these patients. And again, you can see this tumor, obviously this is not suitable for, a lot of management options. Colorectal liver metastasis now becoming like, the hot topic, like almost third most common cancer in the world. 50% of the colorectal liver malignancies develop liver metastasis. Again, there are a lot variety of options available, like surgery. Again, I put transplant query because transplant is also an option. Then local regional therapy, microwave ablation, systemic therapy, and there is an hepatic artery infusion pump. I think this is a brief idea of what are the tumors in the liver. I would like to go on to the fundamentals of liver resection, which is the basic principle when we try to do the liver resection. You can see there are 4 liver slides that liver picture that I have shown on the right corner. These are like segments like right apoplectomy, left lateral segmentectomy, or extended left resections. So we are doing a lot of major resections. So what are the basic principles? What we need to do is we need to have an adequate liver volume, remnant liver volume. So how do we achieve that? Or how do we assess it? So that we can decide we are taking the safe amount of liver and we are leaving good amount of liver so that the patient can survive. So what we can do is we can do a volumetry. Also, we can do an assessment of liver reserve by indocyanine, or sometimes we can do a technique to increase the future liver remnant, like a portal vein embolization or liver partition. The second principle is whenever we do liver surgery, try to avoid major blood loss. Minimizing the blood loss will give a good outcome. This can be achieved by vascular control, meticulous parenchymal transection, and also to avoid major bleeding from the venous side. We always say to the anesthetist, like, keep the CVP less than 5. Again, any surgery we try to do, we always try to do R0 resection. This can be done again like anatomical resection, or you can do resection and some reconstruction and try to do complete resection with lymphadenectomy. And there are newer technologies that can also help to do the liver resection as safe one, like laparoscopic, robotics, or intraoperative navigation system. And I mentioned about 3D printing, which I will tell you, which is an advanced technique. I'll let you know. So now, just a rough guide. We divide the liver into normal liver or patient who have moderate liver disease, maybe a fatty liver or post-chemotherapy liver, or patient has got cirrhosis. Rough guide is normal liver 20 to 25% is adequate, but we always leave a little bit more. For moderate liver disease, 30%, and cirrhotics, minimum 40% of the liver to be preserved as a future liver remnant. And there are techniques that we can use, like maybe this is one where we combine the MRI and the CT. we can get a 3D imaging of the liver. We can assess each and every branch of the hepatic veins, hepatic artery, portal vein, as well as the bile duct, which will help us to decide which plane we are going to go. And then we also know when we do, even on this, we can do a resection and see this is the one that we are going to preserve, this one we are going to take it out. And there is a technique called portal vein embolization. Some of you may know. You can see on the right side, there is an animation which says like you go and block the right portal vein. What eventually happens is the right lobe shrinks and the left lobe grows so that we can leave adequate future liver remnant. On the left side, we have put some pictures. It's a interventional radiology procedure where you can see the first picture is just interventional radiology. Second one is we've blocked the right portal vein. And this is a patient with a less left lobe. And after portal vein embolization, you can see the left lobe has grown a bit. And this is again the picture of a patient who had liver resection after portal vein embolization. On the first picture, you can see the right lobe has got multiple tumors and the left lobe is quite small. So the patient had a portal vein embolization. You can see the left lobe has grown. Now the right lobe has been removed. After removal, also the left lobe grows and actually it helps the patient to preserve the liver function. And sometimes we see multiple bilobar tumors and we may think, no, this is not suitable for any treatment. But again, there are other options available, combination of methods, like you can do a liver resection in a staged manner. In the top row, you can see there are bilobar tumors. We remove the tumor on one side, which we are going to preserve, and then do portal vein embolization, and then remove the diseased liver later and preserve the liver where we have taken the tumors alone. The same thing on the bottom row, not only resection, we can also use other therapies like ablative therapies. For example, if there is 3 tumors on the left side, we can resect one, which is easily resectable. The other 2, if they are deep, we can go for what's called ablation and then portal vein embolization and then remove the diseased liver later on. The portal vein embolization, once you have done it, approximately takes about 4 to 6 weeks before you decide about further management. Again, I told you about the reducing the blood loss. You can have a vascular control. Obviously, everybody knows a Pringle maneuver is like where you can have the complete control of the inflow. So we can also have control of the outflow if we do the dissection on the top. In this picture, you can see they've taken control of the both inflow and outflow. When we do surgery in this type of setting, the surgical field will be bloodless. And these are all the various images where, you know, the inflow, outflow. Here we have taken the whole the hepatic hilar structures as a single Pringle maneuver. And in some cases, we can take individualized vessels. If you want to do a segmental or anatomical resection, you can have a control of each and every vessels before we proceed with the liver resection. Thereby, we can reduce the blood loss. And this is a patient with an HCC with the background cirrhotics. This patient had a successful resection of the tumor with good vascular control. And this patient, obviously, child say the patient did very well after that. And can we do laparoscopic? Yes, we can do laparoscopic liver resection, but there are a few things that we need to know. There are some segments which are laparoscopic friendly, some segments they are not laparoscopic friendly. The segments which are like in the periphery, like segment 2, 3, 4B, 5, and 6, they are laparoscopic friendly. The segments which are high up in the liver, they pose a lot of challenge. But nowadays, with the combination of techniques like hand-assisted procedure, we can still go ahead with the laparoscopic procedure. Sorry. So I'm just going to play a small video on laparoscopic left lateral segmentectomy. You can see there is a tumor on the undersurface of the left lateral segment, and this can be done as an open procedure as well as laparoscopic procedure. Obviously, we know laparoscopic procedure has got advantage. There are a lot of devices that we can use. This is called actually Cayman device, and sometimes we can use like a harmonics and staplers. Combination of these things will help to do the resection safely laparoscopically. In this video, you can also see we use some different types of device which is not available here, but some of the institutes have got. When there is a bleeding, you can see there is a bleeding. We use, this is called what's called aqua mantis, which is actually having the heat energy as well as it just got like a water spilling all over so that it won't, char, as well as it won't make the probe stick to the liver parenchyma so that it would prevent further bleeding. Actually, I'll just move forward this video. The final step is like you do a stapler and take the whole thing away. we can also use what's called intraoperative CUSA. Sorry. Intraoperative CUSA is like we can do an intraoperative ultrasound scan to locate the lesion and mark the lesion. Again, we are taking the control of the inflow so that we can use for Pringle maneuver later on. And then with the help of the intraoperative ultrasound scan, we mark the area. We mark the area and then we also use intraoperative. This is intraoperative CUSA. What it does is CUSA is like nothing but Cavitron ultrasonic suction aspirator. It breaks all the hepatocytes but doesn't touch the major vessels and bile ducts so that we can easily identify them and precisely we can secure them either with a clips, suture or stapler, whatever it is. Once we use this CUSA, we can take the tissue completely and it leaves the field bloodless with no bile leak. That is the idea of using CUSA. Sorry. So the another thing that I've mentioned about is the hepatic artery infusion pump. This is helpful in patients with liver disease, with especially the colorectal liver metastasis we have used in this case, where what we have done is to prevent future recurrence of the disease. We can use systemic chemotherapy, but this is one liver-directed therapy where you place the catheter into the GDA so that it can selectively give chemotherapy to the liver and then to avoid, so that we can avoid systemic therapy, and also we can give a high concentrated chemotherapy to the liver, which helps if there is a small mets that can also be treated with that, as well as it can prevent future recurrence. This is the liver which has got a huge tumor. This is a bit more advanced technique, what we call it as ex vivo resection. I'll tell you what happens in this case, courtesy from Cleveland Clinic. What we've done is we have done a 3D imaging, what I mentioned to you earlier called Mavis technique. We exactly locate where the tumor is, how closer to the vasculature as well as the bile duct. Then there was a 3D printing was done. It's like the replica has been prepared. I'm showing because now the liver has been taken out, but this replica was prepared before surgery. So in the replica itself, we can do a surgery and see which segment we are going to keep, which segment we are going to take it out. You can see the replica, and the surgery has been done in the back table with the liver surrounded by ice. It's like you remove the whole liver from the patient and do the surgery in the table and try and resect the part of the tumor, and you progress and you have everything planned because of the 3D replica, and then you remove the tumorous side, and that has been removed, and you compare with the non-tumorous side, which has got its own inflow as well as outflow. This liver has been reimplanted. This is an advanced technique which is called ex vivo. Again, as a transplant surgeon, I don't want to conclude my presentation without mentioning about transplantation. So we know we have discussed last time hepatocellular carcinoma. We have Milan criteria and UCSF criteria, and this helps to decide whether this patient goes for liver transplant or not. The other malignancies, including neuroendocrine liver metastasis, colorectal liver metastasis, and cholangiocarcinoma, they can also be transplanted. Neuroendocrine, there is well-established criteria for transplant. Colorectal liver metastasis recently gained more acceptance. I can say it starts in Netherlands, but now most of the centers in the Western world are doing transplant for colorectal liver metastasis. Cholangiocarcinoma, it's been approved for do transplant cholangiocarcinoma, but it's under strict protocol because we have a very strict protocol in doing a transplant in cholangiocarcinoma patients. Again, this slide is very close to my heart. Like the liver surgery is not only by the liver surgeon. There are a lot of people to work along with us so that we can get the good outcome for the patient, including oncologists, radiologists, hepatologists, other supportive care specialists. The take-home message from my presentation is, as we all thought in the past, liver cancer actually is treatable. It's not like end of the game, but it needs multidisciplinary and multimodal approach. Understanding the liver anatomy and adopting a newer techniques and devices, which actually is going to evolve further and further and further. It continue to improve the outcome. And again, there are new targeted therapies are available, which will help to improve the survival. Again, even though we are showing all these techniques, including ex vivo resection, some tumors are still challenging to treat. Sometimes we may have to say to the patient, sorry, we are not able to offer any management, but that is a minority of the patients. Thank you, and I'm happy to take any questions. Ilango, we can't hear you.
There is only one question here. What's the current practice of the utility of liver transplantation in intrahepatic cholangiocarcinoma? Any consensus or a definitive guideline?
There are a lot of criteria. Hyla cholangiocarcinoma, we have a lot of criteria. You know that, right? Hyla cholangiocarcinoma less than 3 centimeter, no extrahepatic disease, no lymph nodes. The patient should be stable on chemotherapy for at least 6 months. Then they will go for liver transplant. But for intrahepatic cholangiocarcinoma, interestingly, there are new protocols. What we have to do is we have to have a confirmed tumor on biopsy without extrahepatic disease. And we also need to get US guided biopsy of any lymph nodes. And then we have to give chemotherapy, and the patient should be stable for at least 6 months. And then we have to do a transplant, and the patient has to have a post-transplant adjuvant chemotherapy. That is a protocol actually that is being developed in MD Anderson.
So till recently, it was considered as a contraindication for transplant.
Sorry.
Yeah. You have a comment to make?
Me?
No. You see.
No, one second. Ilango, how do I go back to the screen? Because I'm not able to see any chats or anything because I'm sharing the screen. Do I have to put it off or?
No, you can actually share and then see the chat itself. So I'll read out the questions for you. What is the role of ALPS in liver metastasis, especially colorectal liver metastasis? That's from Dr. Pavan.
What is the role of?
ALPS.
Oh, yeah. ALPS has been tried. I mean, like when I was in Birmingham, that was new and we started doing it. But the problem with the ALPS is the morbidity as well as the mortality is quite high. And the people who are so enthusiastic about ALPS later on give up ALPS because of the morbidity and mortality. But still some centers are doing a lot of papers come out regarding ALPS. The only thing is it's actually modified version of the portal vein embolization, where here you have to wait for almost like 4 to 6 weeks. There you can wait hardly a week or 10 days, to remove the disease part of the liver. The only one thing that we feel like when we do portal vein embolization, wait for 4 to 6 weeks. If the patient develops mets in the liver that we're going to preserve, that means the tumor is quite aggressive, even though we think we can try and do a curative resection, but still it's quite aggressive tumors. So that gives a rough guide about the tumor biology. So most of the centers in the Western, they are not doing, ALPS now, and then they are mainly doing portal vein embolization as well as like a staged hepatectomy. That's what my view on ALPS.
Fair enough. Dr. Oliul Islam Biplab. So in CRC liver metastasis, when do we go for surgery or palliative option? How do you make that choice?
So the choice is if you can save, depending upon the liver status. If the patient is very good liver without cirrhosis, or patient not on chemotherapy, or you can preserve as much as the FLR, and if you can safely do the liver resection, yes, we can do a liver resection, provided there is no extrahepatic metastasis. Again, these patients should undergo adjuvant chemo after liver resection to prevent further recurrence. I can tell you, I've seen a patient who had come for third time for colorectal liver metastasis resection over a period of 10 years. First time, after 4 years, he come back with a recurrence. Then patient had liver resection, come back again with the recurrence, another 4 years, had liver resection. What happens is, once you've done the surgery, the liver is very clever enough and the body is actually, tell the liver you need to grow, then the liver grows. So we can do further resection. Obviously, when you go further and further, obviously the surgical procedure may be a bit more challenging.
Dr. Oliul, Mahesh, I'll add a comment on this. So For CRC liver metastasis, the key thing is to know whether there is an extrahepatic disease. So first decision, if there is extrahepatic disease, probably palliation is the best option. When you have only liver alone disease, I teach something like this. You can read up as San Francisco Consensus Conference for Colorectal Liver Metastasis. The way I teach is this, is to remember these numbers, 2, 3, 6, and 70, okay? If the tumor involves both the portal veins or the 3 hepatic veins, or it involves more than 6 segments of the liver or 70% of the liver volume, then this patient cannot go for surgery first. They have to go for preoperative neoadjuvant chemotherapy. If the neoadjuvant chemotherapy downsizes the disease and you are able to do the surgery, Dr. Mahesh gave you a lot of options for surgery, so I'm not going into the surgery. In those cases, you can undergo surgery. If the patient does not meet criteria or if the patient expresses progression of the disease, then you go for palliation. Is that very simple? So that's one thing. So next question to Mahesh is, what is the management of a large HCC in a non-cirrhotic patient? Size is 14 into 12 into 11 with right lobe involvement, then involvement of right portal vein and right hepatic vein with adequate FLR. Child A, ECOG 1.
Wow. What a nice question. See,
Dr. Manoj.
I think child A, ECOG status 1, and if it is resectable, I would go ahead with the resection. And obviously is out of transplant criteria. So here the situation is either you try and attempt resection or put the patient on palliative care. I think I would always try to give the best option to the patient. I will have a detailed discussion with the patient. But in this scenario, if it is, say, you said right hepatic vein involvement, I don't know how far it's going into the IVC or something like that. If it is just right hepatic vein, I think right hepatectomy can be done in this situation. That's what I would do. Ilango, any other comments?
Yeah, I will certainly agree with you. I also believe in aggressive resections for these tumors. They are still better than palliative options. So we have more questions coming up. In ex vivo resection, this is from Aquas. Okay. Is the model used as a simulation before surgery, or do you use during the operation to guide immediately before the resection?
No, actually this was prepared because we have that 3D printing technique. So we can have the replica of it. And then we designed, actually the company, and what it designs, you need to do the resection, preserving outflow, inflow for the segment that we're going to preserve. So we know exactly where we need to go. So we do this before, we have a long discussion, and we exactly use that model, but we cannot, during the surgery navigate all the time, but we use intraoperative ultrasound scans to locate where the vessels are. Then we use it as a guide and go. But we use this replica saying that this is where we need to go. This is what we need to preserve so that we can safely reimplant the liver. That's what we do.
Okay. Now, what's the indication for PET-CT in HCC? This is from Dr. Abhijit.
PET-CT in HCC is with the liver-only disease, the PET-CT may not be helpful. But if there is an extra hepatic disease, PET-CT is very helpful in pick up those things. And I think we discussed this last time when Dr. Hema was mentioning about we can do a CT chest and a bone scan. So that's what most of the centers do. But now only thing that we want to rule out is most of the time we can see the liver tumor burden of HCC by CT scan alone most of the time, or we can do an MRI. But only thing we want to rule out is extra hepatic disease, for which PET is very useful. So nowadays what we personally I do a CT triple phase to assess the liver and the tumor, and do a PET to make sure there is no extra hepatic disease. So PET-CT is very helpful in HCC as well.
A little more detail on the hepatic artery infusion pump, and which scenario do we use that?
I can tell you that like in our center in Cleveland, I tried to get the pump here, which is very difficult. I'm not able to find the company which is making the pump. Basically, I'll tell you what it is. It's a pump which we can put it in the subcutaneous pouch, and the capacity of the pump is only 30 ml. The pump actually delivers 2 ml per day, that much slow. It's not like so high amount of fluid that goes through it. what we do is during the surgery, we go and put the catheter of the pump into the GDA in such a way that the tip actually lies at the junction of the GDA and the hepatic artery. So initially we try to give methylene blue first, so that we need to know whether any lymphatics from the liver which is communicating with the duodenum or the stomach or something. So if there is anything, we need to disconnect all those things so that the chemotherapy will not come back to the duodenum. And then we give the chemotherapy for 2 to 4 weeks. Every 2 weeks, initially we give heparinized saline so that the catheter will be patent. And after 4 weeks, we start the chemotherapy. The scenario that we have used for hepatic artery infusion pump is colorectal liver malignancy, but it can also be used in HCC also. But my main experience with the hepatic artery infusion pump is with the colorectal liver mets, where you see like a bilateral liver mets, you do a wedge resection and right whole liver resection, and you have to give adjuvant chemotherapy. But sometimes the patient has got a lot of chemotherapy pre-op and they are very exhausted. It's very difficult to put them through the same thing again in the post-op. In those scenarios, we can use this so that we can limit the chemotherapy to a liver alone, so the patient will not have any systemic side effects. That's the main idea of doing a hepatic artery infusion pump. And I've seen a lot of patients where after the hepatic infusion pump, some of the tiny small mets, even if you missed it, they disappear after the hepatic infusion pump. And this is a lifelong, this is going to stay there for lifelong. Sometimes the patient doesn't want to keep the pump, then we can take only the pump alone and just put a knot on the catheter and leave it inside.
Okay. Sir, is re-resection possible in the case of recurrent HCC? For example, after left hepatectomy child A, what should be the treatment options? This is from Dr. Pramod.
See, once it's recurring, I would think it's not like it will, even if you do second time, it will appear again. I would always safely counsel this patient for transplant rather than attempting a re-resection, because these patients will do very well after transplant.
So it's called salvage transplant.
I can tell you once, we have done it, but not like re-resection. Once we have got a previous question, they were asking about like a 12, 14 centimeter HCC, and then we both said we are going to do resection. Once you have done that, and then the patient, at the time he was not suitable for transplant because of the size of the tumor, but when they recurred, they were within Milan criteria. Then we went ahead and did the transplant, and the patient was doing very well. So the question is, if it's recurrent, I would think about transplant rather than re-resection.
Treatment option for multinodular HCC, 3 or more, largest less than 3 centimeters, in a child A patient, resection or TACE?
Child A patient. Multinodular, always, it's quite tricky for resection. I would go for local regional therapy and see whether that will help to make the patient coming under the criteria so that we can do a transplant, or whether we can also assess whether these tumors will respond to treatment or not. I would not suggest resection in these patients. I would go for local regional therapy. TACE would be a good option for this.
PET-CT is recommended in poorly differentiated HCC. So how do you know before PET-CT that it is poorly differentiated, as we don't do biopsy for diagnosis? And PET-CT is not very helpful in well-differentiated HCC. So,
Pratik, right? I completely agree with Pratik. Well-differentiated HCC will not take FTG, so they won't show up on the PET-CT. And if the PET-CT shows avidity, that means the tumor is poorly differentiated. There is no need for us to take a biopsy to prove that before doing planning any sort of management. And I completely agree. Again, the PET-CT is mainly helpful to make sure extrahepatic disease. On top of that, we can also pick up poorly differentiated HCC. That's what my take on PET in HCC.
Excellent. What are the indications for staging laparoscopy in HCC, Rajesh? Oh, the questions are getting interesting, Mahesh.
Quite interesting. See, any tumor, I mean, if it is secondaries, for example, colorectal liver mets or any other cancer resection I'm doing, for example, pancreas or gallbladder bed resection or something like that, GP tumors, always put a laparoscopy before doing a surgery because to make sure there is no mets. But in HCC, it's quite interesting. The spread usually not peritoneum. It's always either to the lungs or to the lymph nodes or to the bone. So most of the time, we will be able to pick up these things in the pre-op investigations alone. I've not done so far a staging lab in HCC. Ilango, do you?
No. The decision is already made on imaging.
Yeah. What is it?
And after resection in liver failure due to less volume, what's the role of MARS and other liver support?
Oh my God. I don't want to go into that stage at all in the first place because we always be very careful to decide, whether the patient has got adequate liver. It's a very tricky situation to manage. Most of the time, they do have only supportive management. I have not had any experience with the MARS, but supportive management means giving albumin, treating if the patient developed renal failure because of the jaundice, trying have some supportive therapy with the dialysis, improving the nutrition, all those things. If the patient survives for more than 4 weeks, most of the liver will regenerate, the liver failure will get better, provided the background liver is okay, not like a cirrhosis, where the regeneration is not that much good, as well as the patient did not have a previous portal embolization, where the liver is already exhausted. So I think that situation is tricky. I've seen the mortality in those situations is quite high.
So from Dr. Nilendra Yashashvi, what are your comments about isolated hepatic perfusion?
Means? Is it like a hepatic artery infusion pump or what?
The isolated hepatic perfusion, you should get the complete vascular isolation of the liver. And then using a pump, you should put the chemotherapy into the liver and then bring it out in the circulation. So that is again used for colorectal liver metastasis. It has been studied extensively. But I think it has all been given up because the chemotherapy is getting better and better. And if you discuss with the oncology groups, the people who are doing isolated hepatic perfusions have become extremely less. It's a technique which you can know as a postgraduate student for the sake of examinations, but in practice, it has become extremely limited. Dr. Nilendra, I hope that satisfies you.
Can I add one more comment on it?
Yeah, sure.
So,
go ahead.
Dr. Who is that? Dr. Nilendra, right? So what, the hepatic artery infusion pump has been, I think the Mayo group is the one who did the lot of hepatic artery infusion pump in 1980s and 90s and something like that. At the time, the only option we had was 5-fluorouracil that is quite toxic to the liver, and most of the patients didn't do very well. They stopped all the hepatic artery infusion pump at that point. But now, in this century after, I think 2014-15, I think the FUDR is less toxic and has got a good results. The people are actually, the use of hepatic artery infusion pump is actually gaining a little bit more speed. Some of the centers have started doing it in the West, but in India, I don't think anybody is doing it. I have no idea.
What is CT or MRI? What is preferred in HCC, whether it depends on size and cirrhosis? This is from Dr. Abhijit.
I would go for CT because that is easily available everywhere, and we can, easily characterize the lesions. The MRI would be very useful when the lesions are too small to characterize on the CT. Then we can go ahead with the MRI. But particularly if the patient had an MRI, I wouldn't complain.
Okay. Is bone scan recommended for all cases, or is there a size criteria to decide the utility of a bone scan?
If you're planning for a surgical resection, obviously better to get some investigation to make sure there is no extrahepatic disease, whether it's a bone scan or a PET scan. I would like to get it before planning any surgical management. One more, what is the management protocol for net liver metastasis?
Yeah. No, you go ahead.
Net is actually interesting one. Sometimes you don't need to do anything. You just give medical management. They do very well. And resection has been done, and octreotide, tagged nuclear therapy has been done, as well as the systemic treatment with octreotide has been done. Most of them, they do very well. The prognosis, most of them are good. Again, recently, there are protocols for liver mets if it is bilobar multiple. then transplant would be an option, because these tumors do well even after transplant. And the criteria is like something like not more than 50% of the liver has been involved, and there is no extrahepatic disease. The patient should be stable enough on whatever the current therapy. So there are certain criteria for the transplant for neuroendocrine tumors, liver mets. But depending upon what is the resource available locally, then we can decide.
I think that's a separate topic. I think we should have it. So please wait for us to prepare that and then share it with you all. And the HK as the Hong Kong criteria is more liberal in terms of resection for HCC. What are your comments on the Hong Kong criteria versus BCLC for HCC management?
I don't have an idea. You take that question. I don't know what is Hong Kong.
The last time we shared something very similar to the Hong Kong criteria is very similar to the one which we shared on the HCC detailed discussion.
Okay.
And a lot of us in liver surgery feel that BCLC is extremely restrictive, and it is evolving into a much better system with more and more additional aspects. But for the lack of time, I think this is what we can share now. We'll share more on the HCC discussions in the subsequent classes.
Are there any indications for liver first resection in synchronous rectal metastasis patient who cannot tolerate synchronous resection of primary metastasis? Absolutely. This is a lot of debate going on regarding whether the primary first or the secondary first. And liver surgeons always say liver cancer kills the patient, so liver first. Primary surgeon says if you don't take the primary, there will be more metastasis, so you have to do the primary first. So my principle is simple. If the primary resection is bigger and the liver resection also bigger, I wouldn't combine both. If there is a small wedge resection, primary surgery is a bigger one, I would combine both together. Most of them, they don't do any issues. Again, the same way, if the liver resection is big and the primary resection is small, then I would combine. But if it is both are major resection, I wouldn't combine both surgeries. Here, it's again, you can go for liver resection or a primary, whatever is suitable for that patient at that moment, and then you do the other surgery later on. There is no right and wrong answer. I think there is a trial called EPOC trial that compares this. They have not come to any consensus which should be done first.
Mahesh, even in the presence of a larger team, do you still follow this? I mean, you have 2 or 3 surgeons working with you. All of them are liver surgeons. All of them are GI surgeons. And
no, it's not about the number of surgeons. It's about the patient. No, patient has to tolerate both major procedures. I've seen disasters with major rectal resection as well as the right apoplectomy. If the patient develops complication, the patient will not have any reserve. Especially these malignant patients, they don't have a lot of reserve. So I would be a little bit more conservative in this situation.
Yeah. That's exactly what I want the younger surgeons to understand. It is patient dependent. It is not the surgeon dependent interest on doing these synchronous resections. Thank you. I think if you have further questions, you can catch up on Facebook. We will have to wind down for the next session starting at 8 o'clock. Mahesh, great lecture.
Ilango, the next session is 8:30. If you have, because
we have time.
Yeah, you can.
So you're welcome to ask more questions, Mahesh.
Yeah.
Yeah, Mahesh is available, so we can take more questions if you have any questions.
There is someone, does it mean that you do PET-CT in all cases of HCC? I think we have answered already, right? I think if it is available, I would go ahead with the PET-CT. If it is not available, then CT abdomen and chest and bone scan. If there is any other questions? Oh, what is that?
So I will ask a few questions for the sake of the youngsters.
Sure.
So when do you think a liver surgeon, a postgraduate student should consider taking up liver surgery or going for further training in liver surgery? So how is the pathway you recommend for them?
I think if you're in general surgery postgraduate, then I think you need to think about, the next super specialty level program. Either you can do here or abroad, wherever, it's possible for you to go. And if you're doing MCH here, obviously you will do lot of variety of things, including from esophagus to rectum and anus, and including the liver. If you want to have a specific liver exposure, what you need to do is you need to attach with the unit where they're doing a lot of liver cases, including transplants or even just HBB units. There are a lot of HBB units who don't do transplant, but a lot of HBB cases. You have to get attached with some of the units and get trained from there, and also try to see various techniques. When you're going into the type of situation, probably you will learn a lot, and you will also develop some more finer nitty-gritty of all the finer techniques from yourself, and then include everything and then start your career. Always have some mentor with you, so that in the initial few cases, then you'll be fine. If you know the principles of liver resection and liver surgery, any surgery, you'll be doing good. I think the training is the key. Either you can get it during a postgraduate training, or if you get abroad as well as in specific centers in India, that would help you to do that. That's what I would recommend if you want to do liver surgery as your profession to do, in future.
So there are a couple of questions on liver transplant training. Where in India can we train for liver transplantation?
Wow, what a great question. We have Professor Rela in Chennai who has got some fellowship, I think, for liver transplant. I think in Delhi, Medanta, Apollo, I think they are also taking trainees, and even ILBS, there are options for you to get training in liver transplant. Any other centers?
So those are the good options for you to go for.
Shankar, Ilango, small information. Saturday, Dr. Rila will be live on Learning General Surgery.
Wow. So
discussing health economics during COVID.
Okay. So probably at that time, training questions on transplant will not be appropriate. Right. I think we should get Prof to do something on these training sessions as well. For
next week he'll be doing something on liver.
Okay, sir. Okay, sir.
So one comment I would like to make for the audience here. Some are like MCH, some are specifically want to do HBB, some are general surgeons. I think I've just given an overview. It's a broad topic. Management of liver malignancy. So, for example, transplant for liver malignancies, it's per se is a separate topic. HCC is a separate topic. Transplant for cholangiocarcinoma itself is a separate topic. There are a lot of things that we can discuss. What I would like to highlight with this presentation is, like, when you have a patient who has got liver tumor, whether it is a single tumor, multiple tumor, what we need to do is we should not say this is, we cannot do anything for this type of situation. I would like to give an insight that there are treatment options available, but this can be done in a tertiary care center where there are specialists available, so that we can give some hope to the patients. That's one thing. Second thing is, I've shown all the videos and surgery, so that people who are really interested, they can, it creates some enthusiasm among those people who wants to do HBB surgery, so they can look at the pathways of where they can get training and go up in their profession. That is the idea of giving this presentation.
So do any of you sirs provide fellowship in liver transplant or surgery? At present, right now, I don't have any fellowship program in our place. But in future, we will consider that. Yeah, the number of surgeries that is required for a good training program as per the US guidelines, the ASTS guidelines, is 45 livers. So there are very few centers who can take up a couple of fellows to do the liver transplant program. Those details Dr. Mahesh has already provided for you. And I hope as the number increases, we'll have more and more fellowship programs in liver surgery and transplant, including ours too. So there is one interesting general question: is the future towards subspecialization and first tier cities? Patta sir, I need your answer first, and then we'll go to Mahesh.
I don't know whether you heard that discussion of how to extend general. No. are we training quality surgeons?
Yeah.
In that, Dr. Vijay Kumar was commenting that the health minister at the central level, when he was asked that why are you increasing MCH seats while patient numbers are not increasing, he said this is to push surgeons to the periphery. See, the number of MCH people increase, obviously they have to go to two-tier cities. So that is the idea behind that. That's a very, very nasty answer though, but that's what was given. Dr. Vijay Kumar from Anapaya University was commenting. I don't know if I remember he's saying that.
Yeah, I remember.
Now, actually, in two-tier cities, also they are looking for specialists, super specialists. Okay, if they want to get a lab poly done, they would like to go to MC surgical gastro. Now, things have come to such a state, and with all the social media, I think, as Dr. Girija Sharma is writing much in detail as to how surgeons can do very well in a place away from metro. I think the future is there. We have to come to accept that, because many of the metro cities have got many of the specialists in large numbers, and their work itself is diluted, but periphery is still, it's all wide open. Having said that, if you are good, you can survive anywhere, including a small village.
Yeah.
Completely agree, sir. Completely agree.
Yeah. So it depends on you.
I think it's a perception of the public, right? Especially in the metro cities, where people think like for any disease, they want to go to a specialist specifically for that particular disease. I can remember when I was in Cleveland, there was a patient coming in with a pleural effusion, and I referred the patient to the pulmonologist. He asked me, I don't want pulmonologist, I want a pleural specialist. And I said, I don't know. I don't know any pleural specialist available here. So this is the people's mind. They think for each and every, organ, there is a specialist who can do better job. But I think, in metro cities, mentality is like that. But as Dr. Patta sir mentioned, in periphery, I think the world is yours over there. You can do a lot in the periphery.
True. I actually feel that, Dr. Pramod, this is not to discourage people from taking up specialties. If you read Dr. Girija Sharma's posts on Facebook, it is very inspiring. And I mean, imagine a general surgeon who can provide most of the services that is required at a tier 2 city, and with a lot of confidence. And you should aim for people like that. See, narrower and narrower specialties like me, like staying on HPV surgery, some people staying only on liver transplant alone. I think the world is coming to a change, that probably worked well for the previous generation, but it is not healthy, or it is not economically viable to have a single specialty surgeons working in a healthcare environment. It's difficult to provide. See, I have completely, I worked as a general surgeon for a long time. So I still remember how to do my toenail excisions or diabetic foods and things like that, but it's not the same. If somebody joins MS, then joins MCH, then goes for HPV, and then goes for transplant, the in-between years, they are very cramped, and your vision becomes extremely narrow, so that you cannot know anything about putting in an ICD for or a chest drain for a chest injury, which comes into your ER. So we become extremely narrow-minded. So that is something which may not be very healthy for our country. This is my perception. See, I've been a general surgeon for 7 years, then worked in GI surgery. I stayed there for another 7 years before I went for HPV and transplant. So this is my perspective. So I still believe that one should train well during general surgery and have excellent exposure. The key is to assist as many specialists as possible, so that you pick up their tips and you will be able to treat your patients better at the time of their need. That's the key. And there is one more question, India or abroad for transplant training? Mahesh, that's a controversial topic.
A very controversial topic. I think a lot of people have seen Indian trained as well as abroad trained. If wherever you go and get training, learn the basics as well as the proper techniques, as well as the way that manage the patient. If you know that, then I think you can go and work in a unit where you can do transplant. There is no doubt in it. But basically, you need to put your heart into it and learn everything. How much you can learn from there, and then it's still ongoing process. Even though we have completed our training, it's not ending over there saying that I've learned everything, I can do everything. It's not like that. Even then, now and then, we can see a lot of new things that we are still learning. So you should have a basic training, then work in a unit where a lot of transplant being done. That will shape you in a better way.
But that doesn't answer the question, Dr. Maheswaran. Should he have
that is a controversial topic, sir.
Yes or no is the answer.
So we can take this up for a discussion, sir.
For me, I can tell you, I had my transplant training initially in the UK. Okay, but I want to see more different ways of doing it. That's why I went to US. That's why I ended up in having a transplant training in the US. And I've seen a lot of people who have been trained here also. They are also doing very fantastic job. I should say that. So there is no comparison either to get a better training in India or abroad. I've not had any training in India in transplant surgery. So it's very difficult for me to see how the training here is. But I can say I've seen people who have been trained in India. They're also doing really good. So it's not like I'm not favoring one side to the other side. I think wherever you go, you learn and come back in a unit. That's what I would recommend, sir.
So this is my feeling. At the point when after my MCH and a couple of years of practice, I wanted to train for transplantation. So I asked one of the first liver transplant surgeons in India about training and my own teachers. So they did give me an options like how we gave, you can go to Delhi, you can go to join with Professor Rela, whose unit was in 2009, he was just starting at that point of time. And you can go to Seoul and a lot of advice. So when I started to look for transplant training opportunities, I saw that structured training is very good. So for structured training, either you have to go to Europe or to US. I think Seoul also, the Asan Memorial Hospital in Seoul has a structured program. And for that structured program, you need to have some mastery of the language. I mean, you cannot just become a technical surgeon in transplantation and expect to know everything. So I wanted to know the whole picture. So I had to choose. So by around 2011, I had started processing this to go to US. And my teachers encouraged me to do this. And they supported me throughout the whole process. So when Dr. Ratnasamy, he would write emails to people and then recommend me. And I got to Pittsburgh. I liked the program. But when you reach the program, the utility of the program entirely depends on the fellow. I mean, I used every bit of the University of Pittsburgh transplant program. I will go to the transplant coordinator's office, sit there, listen to them. They will tell me many stories of transplant, post-transplant follow-up. I had managers, I discussed with them. I used to go to the CORE, which is the organ procurement agency, their manager. So I learned from everybody, the nurses, their training programs. I rounded with them separately. So it was my own interest. And there were fellows who would just do their job and go home. So, so wherever you are, you have to utilize. And the technical training in India has become very good, especially with regard to transplant and live donor transplant. It is very, very good. And a lot of people from US are actually US and UK. They're coming over here to learn live donor liver transplant surgery. And we have become a large transplant training center in the world for live donor liver transplantation. So you have to use every opportunity that is provided in your transplant training. That's all. It is more structured in the West only because it has existed for a longer time period. I think from 1991, people are training in liver transplant in US on a regular basis. Prior to that, I think it was not so well organized. It was only in Pittsburgh and a few centers there. But I think 1991 onwards, it's very structured. It's very structured. That's the only difference. But I'm sure in the coming years, India will also have the same structural training in transplant as well. There is one more question from Dr. Tony Jones. Does training in US for transplantation requires clearing the USMLE first? Obviously, yes. Mahesh has already answered that. And so I want you to have all these things you explore. Whenever we find young surgeons, I mean, there are quite a bit of seniors who will help you out. You can go visit them, stay there for a couple of weeks, see their lifestyle. When I got selected for transplant and I was ready to go to US, one of the transplant surgeons looked at me and said, see, even after having seen my life, have you not changed your mind about doing transplantation? It's really shocking. It's not all rosy on the transplant side. So make your decision very well when you go, because sometimes it may well be a one-way ticket for you. And you have to learn to love what you do. It's a long work, which you may have to work very hard for the rest of your life.
I heard some stories as well.
Sir, I think we can close. Patta sir?
Is he there?
Might be
nice listening to you all, chaps here. Yeah. Now, before closing, all that I can tell all the youngsters who are there, just to make use of the place where they're training or studying, first you get the best of where you are at the moment. Then other things will follow. Thanks, Mahesh, for
thank you, sir,
and a great discussion. Thanks, Ilango, for putting this together. 8:30 we'll be starting the case of the day.
Sure, sir. Sure,
Thank you, everyone.
Thank you, sir. Thank you, everyone. Thank you for being here.